A 28-year-old male patient admitted under the orthopedic team with crush injury. The bloods show AKI, and the urine tech shows blood. What are the cause of these findings?
Okay, so it could be traumatic, like crush injury, massive burns, compartment syndrome. Could be due to acute ischemia with reperfusion injury. Could be because of drugs like statins, and could be exertional due to.
Yeah. Well, you're on the right lines, but
I
uh,
gave all the causes. Yeah. Okay.
yeah, you don't need to give all the causes. The main thing here is this patient injury is likely crush injury. Okay. What is the likely pathophysiology of the current presentation?
Okay. So
Do you know the pathophysiology of the current condition?
I mean the the
It's
trying to.
okay. If you don't know the answer, we don't
I
have
mean,
to.
I don't know how to. I don't know which part to explain, if that makes sense. The
The
kidney
part is the
injury or
pathophysiology.
the rhabdomyolysis.
Either.
Basically,
Say both. It's to be better than saying nothing, right? So just say
okay.
it.
So the rhabdomyolysis, well, it's due to the death of the muscle fibers and due to the crush injury, of course, and they release their contents, which are like the myoglobin and other ions, and then they deposit these substances can go deposit into the renal tubules, which can cause necrosis and renal failure.
Well, you're on the right lines, but well, you're on the right lines. You've said the right things. Uh,
Okay.
I would phrase it a little bit different. Okay. So the current pathophysiology is mainly compartment syndrome. Okay. So the patient had compartment syndrome, which is increase in the intracompartmental pressure of certain muscles more than 30 millimeter mercury, and this will cause pressure on the muscles, release of myoglobin. I wouldn't necessarily say release of its contents. What do you mean by its contents?
I said myoglobin and contents. I meant creatine kinase and some ions.
The main thing is release of myoglobin
Myoglobin. Yes.
to deposit in the renal tubules and cause acute tubular necrosis, and this
Okay.
will lead to renal failure. Okay. What's
Okay.
the clinical picture of compartment syndrome?
So there's pain out of proportion compared to the injury. There's paresthesia. Um, and some of the clinical signs are sensory loss, pain on passive stretching of the limb, and a tense and very swollen limb. And one of the late signs is loss of the pulse of that region.
Okay. When you say pain out of proportion of the injury, what do you actually mean by that?
It is extremely, extremely painful
In proportion to what?
because on the outside you can just see tense and swollen limb clinically, but the patient is
Yeah. So that's
too much.
fine. So it's pain out of proportion to the clinical findings, not to the injury. Because you can have a patient with significant injury and have a
Mhm.
compartment syndrome, right? So it's a pain out of proportion to the clinical finding,
Okay.
right? Okay. What's your initial management in this patient?
Um, Well, I have to measure the intra-compartment pressure,
You don't
and
have
I
to.
have to fasciotomy.
You don't really have to.
Fasciotomy.
Well, that's the confirmed management. It's a definitive management. We're asking what's your initial management. You know the difference between initial management and definitive management?
Okay, then I'll have to go through the ATLS protocol.
Sarah, you're not really saying anything, right? Just take a minute. You know the answer. Just take a minute and think about what you're going to say and then answer the question. Because I'm sure that you know the answer, but you're just not saying that.
Again, I should do
Listen,
the
I'm one of the nurses, and I just called you now as a doctor. Doctor, this patient has significant pain in the legs, and 24 hours ago they had a fall, and they lied on the floor for about 8 hours before they come to the hospital, and the pain is excruciating, not responding to painkillers. What are you going to do?
again ABCD approach.
Can you tell me more? Because ABCD approach is not an
Uh,
answer.
yes. So airway, check the airway, the breathing, the circulation. Um, but in this case,
I don't think it's ABCDE, in my
I
opinion.
think I should do emergency fasciotomy.
Without assessing your patient?
No, I have to assess my patient.
Correct. Without getting bloods, without speaking with the anesthetist, without booking the patient to theater,
Oh, okay.
without getting a registrar involved. So that's the initial management.
Okay.
You want to go immediately and assess the patient, take a bit of history, do clinical examination, most importantly, look, feel, and move the lower limb and see how painful it is. You can measure the intracompartmental pressure if needed, or the diagnosis not confirmed. You can also insert two wide pore cannula in this patient. The
Mhm.
patient has an acute kidney injury. You would like to start them in fluids, okay? And you would like, while inserting a cannula, take some bloods from the patient. Taking bloods, including clotting and Grubel screen. And after that, if it's confirmed compartment syndrome and you would like to do definitive management, which is fasciotomy, you would book the patient into theater. You will consent the patient for fasciotomy. And most importantly, you're going to mention that this is a consent form 1. And I'm going to specifically mention that losing the limb is one of the risks of this operation and this condition. And you're going to escalate to your seniors and you will speak with the anesthetist and book the patient into theater as a CPOD 1 because this is a limb saving operation. Okay, so the
Mhm.
difference between initial management and definitive management is really important to know. Okay, so you have a patient with bowel cancer, right? Query bowel cancer. You don't know the diagnosis yet. What's the initial test to do, and what's the definitive test to do?
Colonoscopy, CT scan, biopsy.
Which one is definitive? Which one is initial?
These are initial. Definitive is the surgical part.
No, definitive diagnosis is the biopsy, right?
Yes.
Biopsy is always definitive. Anything else can be done initial. Doesn't really matter in this case, but in other cases, if we're talking about a patient with, a polytrauma, and they are currently quite unwell, right? Uh, and we know for sure that from the look of it, that they have external bleeding, right? But it's a major polytrauma. So they have like bleeding coming from the lower limb. What's the initial or the first thing to do? And what's the definitive management? What's the first thing to do for a polytrauma patient? Airway management, because
Yes.
this is the AT list, but you can see very obvious bleeding. You're not going to run and stop the bleeding. Obviously, in real life, someone is going to go and help you with that. While you're managing the airway, someone will manage the bleeding, but you should care about the airway more than anything else while doing your assessment. Anyways, your initial management includes lots of points. Most important in the C, put 2 wide pore cannula, take bloods, do lower limb examination, give the patient resuscitation, escalate to your seniors and anesthetist, and discuss with the patient and consent. How to diagnose compartment syndrome in a patient with all touch sensation or sensory motor defect.
This is where we measure the intercompartment pressure.
And how would you treat compartment syndrome? I think you said that.
Yes, we have to do early decompression, emergency fasciotomy.
Okay, and where will you do the incision for which compartments?
There's there are 2 incisions, anterolateral and posteromedial.
Okay, and for which compartments are these?
For the leg compartments, there are 4 compartments.
So are you going to decompress the lateral compartment and the posterior compartment, or lateral, posterior superficial, posterior deep, and anterior compartment? Did you hear me?
Yes,
So which compartments are you going to decompress?
the anterior and the posterior
Wrong.
superficial.
So you always say, I'm going to decompress all the compartments. Yeah?
Okay.
Even if the patient, let's say, you think the mainly affected compartment is anterior, all the compartments will be affected. So you always decompress all the compartments by doing incisions. Okay. And how will you consent this patient for fasciotomy?
I have to explain to him why we have to do the fasciotomy to save the limb and probably prevent kidney injury as well. And of course, inform the patient of all the complications that can happen up until death, like muscle damage, nerve damage, scarring, infection, loss of the limb, amputation might have to be done, kidney failure, and death.
Okay. Sounds good. Um, just one sec. Someone is asking for the meeting link. Okay. Uh, the patient developed AKI. Can you explain why?
Yes, because there's rhabdomyolysis, and the myoglobin that is released is actually toxic for the kidney, and it can cause obstruction with cast formation, and which will lead to renal tubular ischemia and necrosis. Um,
Okay,
yeah, that's it.
that's fine. All right. So that's fine. So Zira, as an overall feedback, I think I don't know why you probably haven't practiced this scenario before, but it was a bit slow, and lots of areas of improvement in the scenario. Really, to be honest with you, um, so I think probably need to read it again and develop more robust answers. Um,
Mm.
okay, it's still for you because this scenario comes with this one. Can you define what is rhabdomyolysis?
Yes, it's the death of the muscles and release of their contents. Uh, which are myoglobin, creatine kinase, and they deposit in the renal tubules and cause renal tubular necrosis and can lead to renal failure.
Yeah, and what are the causes of that?
So causes can be traumatic, like crush injury, massive burns compartment syndrome. Could be exertional due to hyperthermia or very prolonged exercises and seizures. Uh, and other causes could be like drugs, like statins and alcohol.
I see. And what investigations would you do?
So if I'm doing I'll do blood tests. I'll check for creatinine kinase. It's usually elevated 5 times its normal range. We have high levels of lactate, creatinine, and lactate dehydrogenase. Of course, there's myoglobinuria, and we do a urine test, but it doesn't show any RBCs. It's just dark blue urine. Um, Electrolyte disturbances. Uh, then
Yeah, that's fine. What's the management plan?
okay, so it's supportive first of all, and I have to start with IV fluids like saline, um, and then um, oh, we do forced diuresis with mannitol, and then if there are complications like hyperkalemia and renal failure, we have to treat that. Also, we can have hyperuricemia, so allopurinol for that one. And then I have to take the patient to the HDU and monitor the electrolytes and the compartment pressure.
Okay, that's fine. And the monitoring here include ECG, electrolytes, urine output, CK, LDH, myoglobin, and the compartment pressure as well can be monitored. Okay, thank you. This one, you have a patient had a TURP operation and
Mhm.
currently is hypoxic and hypotensive. What are the possible causes of hypoxia and hypotension in this patient? And the confusion, of course.
So the main differential diagnosis would include TURP syndrome, or it can be due to the procedural complication, like it can lead to perforation, lead to sepsis, or hypotension, and due to the large amount of the fluid, it can lead to the hyponatremia, which can lead to confusion, and metabolism of the glycine to ammonia, which contribute with the hyponatremia, can lead to confusion and hypoxia. Over fluid can lead to the pleural edema, which also can lead to hypoxia and confusion.
Yeah. Can you try to make it simple, right? Just make it simple. So what are the possible causes? Just say the possible causes. You don't have to
So
make a story.
the TURP syndrome.
It's right. You answered. You answered. That's fine. So TURP
Okay.
syndrome,
Mhm,
hyponatremia,
mhm.
analgesia and sedation, blood loss, cerebrovascular disease, etc., etc. Right.
Mm.
So just make it simple. What's the definition of TURP syndrome?
So it's a TURP syndrome is a fluid overload due to the procedure of the transurethral dissection of prostate, in which a high amount of the hypoosmolar fluid irrigation
So Naila, I'm sorry. I'll
is
have to
done, which
stop.
is absorbed to the venous.
Okay.
Sorry.
I'll have to stop you. Your answer is great, but there is an important point to mention. One, when you're speaking, if you want to think about what you're going to say next, do not make a sound. Just be silent until you're able to remember. So instead of making the ah sound after each word or two, it doesn't
Okay.
sound good in the exam. So just stay silent, think about it, and take your time. Give yourself just a few seconds before you answer each question. that will look better than thinking about it while you're speaking. All right? It's okay to think while you speak, it's no problem, but the R sound doesn't sound good in the exam. Okay? So again, definition of TURP syndrome.
So, sorry.
It's okay. I'm not
TURP
trying to put
syndrome is
pressure on you.
it's a volume overload, which leads to the hypernatremia during the process of transurethral resection of prostate, and due to the irrigation, the large amount of fluid absorbed through the venous sinuses leads to the hyponatremia.
Yeah. So it's hypotonic, hypovolemic, hyponatremia due to the use of glycine-rich hypotonic irrigation solution, which will be absorbed, leading to severe dilution of hyponatremia. But your answer is great, no problem at all. What's the clinical picture?
So, patient, in this, like I have to tell in the book is mentioned like with the timing and early features and other features. So it should be like this, or just randomly, like you said, what is the clinical picture?
Just answer the question and we can talk about it.
Okay. So patient will present with the initially with the hypertension and then hypotension. A patient will present with the pulmonary edema, cerebral edema, which can lead to the confusion, and due to the hypotension, renal ischemia, so it can lead to acute renal failure. Pulmonary edema will lead to the congestive heart failure. And due to the cerebral edema, increased intracranial pressure, which lead to the visual disturbance, headache.
I see. Yeah, so there was lots of symptoms basically. So basically, this patient has, like I said, a fluid overload and dilution and hyponatremia. So the main symptoms will be confusion, restlessness. They can get blurred vision, and then hypotension as well, with pulmonary edema and heart failure. Okay, but you said it's still what you said is correct, obviously. What are the causes of confusion in this one?
The causes of the confusion are hypoxia and hyponatremia.
Yeah, and what's your management plan for this patient?
So I will manage this patient according to the CRISP protocol, and I'll shift the patient ITU and immediately stop the procedure, stop all IV fluids, stop all IV fluids, and stop all IV fluids, give diuretics like med, and start a high flow of to the patient. It need ventilatory support. So I will liaise with you registrar in this regard, and monitor electrolytes and then fluid electrolytes.
Okay,
Yeah,
so I think
and monitor electrolytes. Yeah.
So I think your answer lacks the structure, which is a problem. So it doesn't have any structure at all. So you said initially you stopped the fluids and then you kept fiddling around about going to ICU, speaking with the registrar. So just it feels like a very anxious answer. So just try, like I said, take a minute, take a few seconds, think about what you want to say, and arrange your thoughts. So here, I think the safest option is that you're doing an A-to-E approach, okay, according to the CRISP. So if you're currently operating, you'll stop everything. You'll stop the ongoing fluid. If the patient is not intubated, you will consider intubation according to their conscious level after doing GCS. You'll make sure that they have all the bloods taken, electrolytes being monitored, and you're going to correct their hypothermia as well. You can give furosemide for forced diuresis, and after stabilizing the patient, you can send to HDU for sodium replacement. Okay, so that's better in terms of structure. So you always mention A to E at the beginning. You don't necessarily have to start talking about airway, breathing, circulation, etc. But just mention at the beginning that you will follow A to E approach. You will stop the operation, stop all the IV fluids, consider intubation if needed. That's airway, and correcting low blood pressure, correcting electrolytes. That's C. Correcting hypothermia, still C. Giving forced diuresis, still C. And then after doing all of this, you refer to HDU if required for sodium replacement. What will you give hypertonic saline?
Okay. In this
Will you give
patient?
hypertonic? Of course, in this patient, we're not talking about any other patient. Will you give hypertonic saline?
Yeah. And on the sodium levels, if sodium level is less than 110 millimole per millimole, then millimole per liter, so then I will think for the hypertonic saline.
Okay, the answer is simple. Again, make it simple. Yes, I would do if the sodium is less than 110 millimole. That's it. What other systems could be affected as well?
So other systems like it will also affect the lungs, lead to the pulmonary edema, or affect the kidneys, result in acute renal failure, and will affect also brain, increase the intracranial pressure.
Yeah, so multiple other systems can be affected, and the cardiac system as well, and also the lung with pulmonary edema. What's the mechanism of action of different diuretics that you know?
Mechanism of action of the different diuretics in this patient, when we are using furosemide is working on ascending limb of the loop of hand, while mannitol is working on proximal convoluted tubule, thiazide diuretics working on distal convoluted tubule, potassium sparing diuretic and antidiuretic, potassium sparing working on collecting duct and proximal convoluted tubule.
Yeah, but you still didn't explain the mechanism. You just said what are the location of action.
Okay.
But that's not a mechanism.
Working on a loop of Henle and it blocks the channel sodium potassium chloride, thus inhibiting sodium, thus promoting sodium thus promoting so it blocks this channel. Diuretics, they work on the distal convoluted tubule and they work on the sodium chloride channel. Potassium sparing diuretic like Cetone, they work on sodium potassium on the collecting.
Hello?
Yes.
Okay. I think you interrupted. Osmotic diuresis, they work in the proximal tubules and lower finely collecting ducts. They inhibit water and sodium reabsorption. Carbonic anhydrase inhibitor location is the proximal tubules, and it inhibit bicarbonate reabsorption. The others is like you said, apart from the potassium sparing diuretic, they inhibit the mineralocorticoid receptors in the collecting ducts. Okay, so yeah, that's fine. I think as a feedback, when is your exam, Laila?
I haven't received the date yet, but I booked for the October.
October. So you still have 2 months to practice. You will need lots of practice. You will need to sort of develop a way to answer your questions directly without fiddling around. You will need to find a way to basically say the right words or the buzzwords without thinking too much about it. All right.
Okay.
But I think overall, you're doing well in terms of knowledge. Okay, use patient with sodium less than 120, normal plasma and urine osmolarity. What's the normal level of serum sodium?
It's from 135 to 145.
And what's the clinical presentation of hyponatremia?
The clinical presentation depends on the sodium levels. From the mild decrease, we can have confusion and restlessness, and progressively from with moderate to severe decrease in sodium levels, we can have symptoms like muscle weakness, and further, ultimately, it can cause coma.
See, and what are generally the causes of hyponatremia?
The causes of hyponatremia can be diverse, like fluid overload leading to dilutional hypovolemia. Apart from that, if we divide it according to the serum and urine osmolality, so the stuff like renal failure, syndrome of inappropriate ADH excretion, and vomiting. Then we have polydipsia, psychiatric condition, and then other stuff like drug overdose.
Okay, so yeah, well done. But I think you lack a structure again. So try to have a structure in your mind. You can say it can be depletional hyponatremia or dilutional hyponatremia. So that will help you in establishing the causes. So dilutional, you're talking about fluid intake or any of the failures, right? So the failures including endocrinological failure or heart failure, nephrotic syndrome, renal failure, hepatic failure, SIADH, which is gland failure, and pseudohyponatremia as well. That's for dilutional. So dilutional is
Fluid overload.
increased uptake or failures. Okay.
Failures.
On
Okay.
the other side, depletional. So you're losing blood. You're losing sodium, right? You're not necessarily taking much fluids, but you're losing sodium instead. How can you lose sodium? You lose sodium basically from your bowel, from your sweat, and from your urine. Okay, so we're talking about renal loss. So that would be the diuretic if you're taking lots of diuretics. If you have renal sort of Addison's disease as well with mineralocorticoid action, and if you're taking some sort of osmolodiuresis, that will lead to hyponatremia. The non-renal loss, we're talking about the gut and your sweat. The sweat will not necessarily lead to decrease of the sodium because it's very, very minimal. But the gut loss is much more important, like diarrhea and vomiting. That's much easy, isn't it, when you think about it this way?
Yes.
Dilutional and depletional hyponatremia. Okay, what are the investigations? So I've just called you, one of the nurses called you and said, patient sodium is 120. What's the investigation that you're going to ask for?
I will order the urine serum sodium levels, urine sodium levels, urine osmolality, serum osmolality, and then we are going to order ABGs, of course, some enzymes like ADH, aldosterone to renin ratio. Apart from that, I can order RFTs, LFTs, UNEs. So these are the investigations that morning
Yeah, that's fine.
cortisol.
So again, it's simple. Just try to make it simple. So you're gonna get some routine bloods. That's what I wanted to say, because we agreed
Yeah.
that routine bloods, everybody knows what routine bloods are. Unless you're being asked for it, they can ask you what are your routine bloods, and then you can say FPC, UNE, CRP, LFT. Those four are your routine bloods, always. Okay? FPC, UNE, CRP, LFT. Okay, so you're gonna get that anyway as a baseline. And then you can get sodium specials. You can get the paired osmolality, urine sodium and serum sodium, the morning cortisol, the TSH, the lipid profile. I don't understand what was the rationale to get aldosterone to renin ratio at this point. So you start by those and work out your diagnosis, and then you can get special further tests if needed. Okay.
Yeah.
And
Okay.
how ADH is released and what's its function?
ADH is released because of low serum osmolality, which actually stimulates in the hypothalamic center from where ADH is released and is stored in the posterior pituitary gland. And from there, it is then released that acts on the cortical part of the collecting duct.
Yeah, so how is it released? The answer is released from the posterior pituitary gland, right? The two factors that lead to that, increased osmolality or decreased in the volume. So hypovolemia or increased osmolality. Okay. And this leads to basically reabsorption of solute-free water. So you reabsorb water. Okay. What is the half-life of ADH?
Thanks, I'm forgetting it. Sorry.
10 to 20 minutes. Okay. 10 to 20 minutes. It just takes very short course of action. And what are the causes of SIADH?
SIADH can be a complication, paraneoplastic syndrome of lung cancer, small cell lung carcinoma, can be due to the long-term COPD. It can be due to a pituitary tumor. It can be due to hypovolemia. So these are the causes I know.
Yeah, that's fine. So SIADH, like you said, it can be related to multiple things. This diagram is really helpful. So you can have tumors, infection, and trauma. Could be related to the lung, all right? And the lung will basically be paraneoplastic syndrome, like you said, or even pneumonia or TB or small lung carcinoma. Could be related to the kidney, and other causes like increased alcohol withdrawal and trauma, HIV and AIDS. In terms of classification, it could be acute gastronic and volume status and tonicity. And here we're talking about the classifications of hyponatremia, but don't worry about this question. What is the management of hyponatremia?
The management of hyponatremia will depend on the serum sodium levels. If it is between 130 to 135, then we can go with the conservative management. From less than 125, we have to consider, depending on the clinical presentation, if we have to replace the serum sodium with starting with 0.9% NaCl normal saline. If it is a very severe decrease in the serum sodium, like less than 100, then we can add a hypertonic saline like 3% NaCl. Apart from that, the main thing is we have to treat the underlying cause. And if we treat the underlying cause, then the rest of the things will follow.
Yeah, that's right. So I think it's tricky here. So the answer can differ quite a lot from a candidate to another. which is absolutely fine as long as you're saying the right words. Okay. So the key point in this patient, I said to you that this patient sodium is 120. So ideally, you should under only for the 1. Okay. You don't
According to
have to
SNAP.
give me possibilities. So sodium is 120. You classify it. That looked like an acute hyponatremia, and like it's moderate or severe symptoms. Patient is confused, so the patient will need to be urgently admitted to the hospital because this is an acute drop in the sodium with moderate symptoms. So admit, involve HDU, stabilize your patient. They will need to take hypertonic saline. That's the most important point, but obviously you need to do full assessment of their volume status and find out the exact cause and treat it as you said. What if what happens if you corrected sodium if you corrected sodium very rapidly?
So the complication is called as central pontine
What is the
myelinosis.
complication of rapid correction of sodium?
Central pontine myelinosis.
Correct, yeah.
Hello.
So myelinolysis is the
Central pontine.
I
Hello.
heard you, and that's correct. Okay. It's called central pontine. I can hear you. I heard you, and that's correct. I heard you.
Okay.
Can you hear me?
So, yeah, yes, the voice is.
Hello.
Yeah, I can hear you now.
Can you guys hear me? Can everybody else hear
Yes.
me?
Yes, I can hear you.
Okay. So yeah, so that's it. Okay, I get it. Okay. So let me just stop recording now. So you have a woman with well-established diabetes. She has arterial blood pressure of 160 over 100. Plasma pH is 7.3, and urea is 15 millimole, and plasma potassium 6.2, and hemoglobin is 102. Subsequent investigation measures are eGFR is 33. Okay. What is the normal eGFR?
Normal eGFR is greater than 90 mils per minute.
Okay. And what's the rationale of the method that you use for estimating eGFR?
It's an algorithmic approach using tracking the serum creatinine levels. So
What's the
based on
rationale?
the rationale is using an algorithmic approach to measure the serum creatinine levels to estimate the glomerular filtration rate.
Yeah, why do we use creatinine? Why don't you use any other substance in the body?
Creatinine is not produced it's not absorbed, neither produced in the body. So it's accurate. It's a protein that can be used accurately to estimate glomerular filtration rate because it's not produced nor absorbed by the kidney.
Correct. You mean not reabsorbed or secreted instead of produced. Okay,
Yeah.
what's the stage of CKD in this patient?
This patient would be stage 3.
Can you tell me the stages?
Yes, so there's stages 1 to 5. So the station would be stage 3B. Stage 1 will be greater than 90 mils per minute. Stage 2 is 60 to 89. 3 is 45 to 59. 4 is from 30 to 44. 4 is 15 to 29, and 5 is less than 15 mils per minute.
Yeah. So in this patient investigation, what other abnormalities do you see? And can you explain why did this patient have these abnormalities?
Right. So in this patient, this patient is anemic. This patient could have a normocytic normochromic anemia due to the reduction in production of erythropoietin in states of uremia. The toxins can reduce the maturation of red blood cells, so the red blood cells would be fragile. What else? In chronic kidney disease.
So, Chris, just look at the stem and see the abnormalities and tell me what are the abnormalities and why.
Okay.
So you've mentioned hemoglobin, which is good.
Right.
What are other abnormalities you can see? Right.
So the patient is acidotic. This patient can be acidotic because of failure of the nephrons to regulate potassium as well as hydrogen ions. The patient is also hypertensive. Patient is hypertensive because there's chronic retention of sodium and water. Yes.
Can you see anything else?
pH. The patient urea is also, the potassium is also elevated as well. Because
Why?
the patient, because of damage to the nephrons, so the transport proteins may be affected, and the patient will not be able to excrete the potassium, regulate the potassium levels, so potassium is retained in the serum.
Okay, that's fine. So we've mentioned multiple things. The thing is, the main advice for you all, if you're in a scenario and I'm asking a question, I'm always talking about this patient, because I've noticed that you just answer questions in general without actually thinking that there is a patient with a certain scenario that we're talking about. For instance, the hyponatremia case, when Moaza started answering the general treatment for hyponatremia. No, we're talking about a hyponatremia patient with sodium of 120. How are you going to manage this? Again, here, the same thing. When I ask you what are the abnormalities, so you need to remember your scenario and talk about these abnormalities, and be really clear. So you have, my patient is, one is hypertension, and that could be due to salt and water retention and fluid overload. They are also acidotic and hyperkalemic. They are both can be basically causing each other, right? So due to the kidney inability to sort of regulate the electrolytes, there will be less excretion of hydrogen and less excretion of potassium, and also shift of the potassium from the intracellular compartment to the extracellular compartment. That will lead to both hyperkalemia and acidosis. Okay, the patient is also anemic, and that could be normocytic normochromic anemia due to the reduce in production of the erythropoietin. Okay, as you said. So you need to be much more focused on your case. So yeah,
Sir?
the other yeah, go on.
Yeah, there was one the question in hyponatremia station, like we discussed that can we, like in the TURP syndrome, you asked like the question, will you give this hyperosmotic saline to this? So the general rule is if it is less than 110 millimole per liter, we will give this 3% saline to the patient. But in this hyponatremia patient, like you said that the patient is with the 120 millimole liter. So how you are going to manage it? So we are going to give this patient hypertonic saline.
See, yes, generally,
like as you said that you have to say.
Yeah. So generally, if your sodium went down less than 125, you will think about hypertonic saline and HDU admission. Vitamin D and erythropoietin replacement in this patient.
In chronic kidney disease, there's low amounts of 125 hydroxy vitamin D, which leads to reduction, which leads to hypocalcemia. So given vitamin D would assist in improving the levels of 125 hydroxyvitamin D so that there's adequate absorption of calcium from the gut. And this reduces the loss of calcium from the bones,
No,
bone
Chris,
resorption.
Chris, you know the answer very well. Just make it simple.
Okay.
Make it simple.
Yes. Also,
No, say it again. Why do we give vitamin D? Just make it simple. I need a single line of the answer.
because in chronic kidney disease, there's less 125 hydroxyvitamin D produced, and the vitamin D supplement replaces this.
Yeah. So basically, what you want to say, so because for vitamin D to be activated, you need 1 alpha hydroxylase, which is produced by the kidney to produce 125 hydroxy or cholecalciferol, and that will not be produced in patients with chronic kidney disease, and that's why you need to give vitamin D replacement. So basically, vitamin D will not be activated in patients with chronic kidney disease due to the lack of 1 alpha hydroxylase. That's it. Just a single line. Erythropoietin?
Yes. So erythropoietin is no longer produced, or it's reduced in patients with chronic kidney disease, and this leads to anemia. So erythropoietin may need to be replaced. And in chronic kidney disease, there's hypophosphatemia. So phosphate binders are used to reduce the serum levels of phosphate in the serum.
That's fine. That's fine. What are the ECG findings on a patient like this? What are your expected ECG findings?
The patient is hyperkalemic, so there would be a reduction there would be flattening, widening QRS complexes, as well as tented tall T waves.
Okay, and what's your management to hyperkalemia in this patient?
Well, we manage patients according to the CCRISP protocol. Specifically for hyperkalemia, we would want to repolarize this patient, 10 mils of 10% calcium gluconate with 50 mils of 50%
Okay,
of
so you've done an
dextrose.
ECG on this patient and there is no cardiac changes. There is no change. The ECG is absolutely fine. Are you going to still give calcium gluconate?
Yes, because the serum potassium the patient is hyperkalemic, and we would want to drive the potassium intracellularly. I would still repolarize the patient.
But the patient doesn't have any changes in the ECG and no chest pain, nothing. So you give calcium gluconate if there is changes in the ECG.
Okay.
With 6.2, it's very likely that you will find some changes. But I just wanted you to say at the beginning that you're going to do an ECG, and if there is a changes, which you expect that there will be, you will give calcium gluconate.
Okay.
Okay, and what's the next step?
After the calcium gluconate, 50 mils of 50% dextrose, along with 5 to 10 units of insulin.
So Muaz is saying he thinks the cutoff is 6.5. It's actually 6, not 6.5. So if it's more than 6, you would give calcium gluconate even if there is no ECG changes. Okay? But the reason why I'm saying that, the reason why I stopped Chris is to make sure that you say that you're going to do ECG first, look at the changes, and then start calcium gluconate. Okay? But your cutoff point is 6. If the potassium is more than 6, you would give calcium gluconate. Okay?
Yes.
Anyways, what's the next step? So you gave calcium gluconate. What's the effect of calcium gluconate on the potassium level?
Calcium gluconate stabilizes the cardiac membrane.
Yeah, what's the effect of the calcium gluconate on the potassium level?
I'm not aware of any effect of calcium gluconate on the potassium level.
Yeah, you're not aware because there isn't. So it's no effect. So calcium gluconate does not change the potassium level. It stays as it is. It has nothing to do with potassium, but it's merely for cardiac stabilization. Okay? What's your next step? So now you stabilize the heart. What you're going to do next?
Well, I mentioned that I would give the 50 mils of 50% dextrose along with 5 to 10 units of insulin with some intravenous fluids. And I would want to reassess the serum potassium levels within an hour.
Yeah. And anything else that you can offer?
Yes, if the potassium is persistently elevated, we can offer salbutamol,
Okay.
nebulized salbutamol.
Mm-hmm.
And if this patient is persistently hyperkalemic, patient may need dialysis as well.
Yeah, sounds really good. Well done. So I think from the start, Chris, instead of me asking you question, trying to get the answer, you just say it. Okay, just go ahead and say the answer.
Okay.
Okay, but well done. That's for potassium. Trying to think if there was any other question that we can do here, but I don't think there is. Okay, so next is so you have a 78-year-old male patient with dementia, renal impairment, history of recurrent UTI. The creatinine baseline is 250, and now the patient had UTI, nausea, vomiting. Potassium is 8 millimole, sodium is 121, creatinine is 700. Can you tell me what are these findings?
So basically, the patient is having a poor oral intake due to the dementia, and he's having infection due to recurrent UTI. He's having acute renal failure and hyperkalemia with hyponatremia as well.
Well, when I say this patient has acute kidney injury, that's the
Yeah.
main finding for you. This is acute kidney injury. Why is this acute kidney injury?
Due to the increase in the baseline creatinine from 250 to 700.
When do you call it acute kidney injury? What's the cutoff? So let's say the creatinine was 300. Would you still call it acute kidney injury?
No. So within 48 hours?
Not really. So acute kidney injury is increase the creatinine by more than 25% from the baseline.
Okay, sure.
Okay. So if it's a 300, it's at the base, it's at the borderline. If it's 300-5 in this patient, that will be acute kidney injury. So 25% from the baseline.
Okay.
That's what you
Sure.
need to know. This is the right information that you need to know. Okay. So what are the causes of AKI in this patient?
So in this patient, you can divide into three: pre-renal, renal, and post-renal. So pre-renal is basically due to the nausea, vomiting. He's having dehydration. Therefore, there's kidney hyperperfusion. Renal is basically he has recurrent UTI, which could lead to recurrent UTIs. And another thing is that he can have ischemic tubular necrosis due to hypoperfusion. And post-renal could be well, they didn't mention in the stem, but I'm just thinking
Well,
probably
because so basically again the same advice to you. Try to make your answer customized to the current patient.
okay.
Yeah.
Sure.
So you have a 78-year-old, okay, with UTI. So patient with UTI might be worried about pre-renal acute kidney injury, and that would be basically due to hypoperfusion if they underwent into sepsis or urosepsis. That's
Yeah.
one thing as a pre-renal. Or if the cause of the UTI is chronic, dehydration with renal stones or bladder stones and with a post-renal obstruction. Renal cause is still be one of the causes, and that will be acute tubular necrosis due to either pre-renal or obstructive cause. So, because basically any patient with a pre-renal and post-renal, they might end up with a renal cause as well.
Yeah.
So the patient had urinary catheter inserted, and you have drained 1500 ml and then 4 liters per day. Can you explain to me why? What's happening there?
So this is basically the diuretic phase of the AKI.
Yeah, and what is that?
So basically, this I can't remember. So it's basically the distal tubules. They can't concentrate the urine.
Yeah, that's right. But you're just explaining the diuretic phase. But what I'm asking, why is that? Why did this happen? So it happened because the recovery of the glomeruli happens before the distal tubules. So you will be able to filtrate, but you will not be able to reabsorb. Does it make sense?
Yeah.
Yeah? Okay.
Yeah.
Why uremic patients are anemic?
Because they can have accumulation of the uremic toxins, which suppresses your bone marrow, and it has short RBC lifespan. It also can cause reduced erythropoietin production.
Yeah. So it's
And,
mainly we're just asking about uremic patients. Just be specific in your answer. So uremia is a toxin that affects the bone marrow, like you said, and the erythropoietin, and also the osteitis fibrosa cystica. What are the ethical issues in dialyzing a 77-year-old man patient with dementia?
So patient with dementia, they have low AMTs, so your mental score, therefore they cannot give the consent. So we have to look in the best interest for the benefit of the patient.
Yeah.
Yeah. So I will ask for a consent for, and I will have 2 doctors or consultant signatures.
Yeah, that's fine. Perfect. So that's everything from our scenarios today. Do you guys have any questions?